Good morning, everyone, and welcome again. I'm Nancy Conlive, and I'm the co-founder and facilitator of the Monmouth and Ocean County Brain Tumor Support Group, one of the sponsors of today's event, and also I've been on the planning committee with a terrific team of people who have volunteered lots of time and effort to put this wonderful day together for all of you. It's also my pleasure to be introducing our guest speaker, so let me tell you a little bit about him. This is our keynote speaker. I first met Dr. Steve Brem over 10 years ago at one of the conferences from the Florida Brain Tumor Association. He was formerly a neurosurgeon at the Moffitt Cancer Center in Tampa, but Dr. Brem has spoken at many conferences across the United States. He's always offered his knowledge and his sensitivity and his interest to anyone who had a brain tumor and was interested in information. He, over 2 years ago, made the move to the Hospital of the University of Pennsylvania, which is a delight for all of us who are in this area. He is co-director of the Brain Tumor Center there and a professor of neurosurgery. And he is also, well, I like to call him Dr. Minch, for those of you who know what that word means. He's such a caring human being who is available virtually 24/7. He gives his cell phone to his patients. He's just there to answer questions and to provide services and information to anyone who needs it. So we're so thrilled to have Dr. Brem here, and please join me in welcoming Dr. Steve Brem.
Thank you, Nancy. And I'm really honored to be here today. It's a once-in-a-lifetime opportunity. And I want to congratulate all the people here who are survivors and fighters in this. And Matt, where's Matt? That was a great introduction. And you hit all the right themes about connectivity, and that's perfect. And de-siloing. And I actually was supposed to be at an advisory board meeting today, but when I heard Al Masella invited me, he's always been one of my heroes, so I got excused from that, and I'm very proud to be here. Al, could you accept a gift from me? I have a book. It's called Truth in Small Doses by Clifton Leaf, and many of you may have heard about this book, but Clifton Leaf's a very famous writer, and like Al Masella, he believes that if people got to work together, that we could really make tremendous impact in cancer. And I'm seeing in the last few years with the summit meetings, with collaboratives, with the National and the American Brain Tumor Association, really bringing people together, that tremendous progress is being made. Al Masella was one of my heroes years ago when we were just fiddling with computers. We didn't have the amazing computers we have today. He knew that information is powerful, and we have to get the word out. And so, Al, you've done so much for the community. Nancy, that was a wonderful introduction. Thank you very much. And the Florida Brain Tumor Association, we used to have Dave Bailey sing, and thank goodness for everybody here. I'm many things, but I'm not a singer. So I won't be singing. But if I were, I would get Johnny Denver here to saying, gee, it's good to be back home again. I have to admit that I am a Jersey boy, or proud to be a Jersey boy, and I met Stan yesterday. Stan, are you here? And Stan and I go back to Rutgers when it was, and I found some shocking news yesterday that they have changed the song of Rutgers, so nothing is sacred, and a venerable institution. It's still on the banks of the Raritan, but I think they've changed their college song. So now I'm going to tell you a story that's partially true, and it's very important. There was a surgeon scientist in San Diego. His name was Brian, and he never did anything wrong. And on the weekends, he had supreme pleasure going on his bike, on his Harley, and he went up the coastal Route 1, you probably know it, on the Pacific, and he loved it. And one day St. Peter came to him and said, you know, Brian, the Lord wants to bless you, and anything you want, we will grant to you. And Brian said, that's great. I love the ocean. If you could build me a highway that would go from San Diego all the way to Honolulu, I would be the happiest man in the world, just the, the blue Pacific. I would love it. And St. Peter got upset, and he said, are you kidding me? You know how many resources that would take to build one highway for one person. What's your next wish? So Brian said, I work at the Scripps, I work at UCSD. If you could help, if I could figure out a way that I could understand the brain wiring, so I'm a neurosurgeon, and I could actually operate on patients and make them the same, keep them whole, or even better. Or if I could figure out the genetic blueprint of brain tumors and develop targeted therapy so each patient would get the right drug at the right time. And if I could understand cancer, I would be the happiest man on earth. St. Peter looked at him and he said, now, let's talk about that highway, 1 or 2 lanes. So it's been So I stand before you, and I know that many of you have great questions, great ideas, and really there's great people in the room, and a lot of the answers are going to come from people in this room. And I look at Dave Zagzag, and I know that, like many of us, he's really, this is more than a job for him. This is, he's obsessed with finding the answers, and I look forward to his talk. And tremendous progress has been made because there are people like Al Masella, Dave Zagzag working at this around the clock, and we are harnessing technology. So I want to tell you parts of my story today. And I joined a group at Penn Neurosurgery over here, and we have 5 dedicated neurosurgical oncologists, Don O'Rourke, Tim Lucas, John Lee, Sean Grady, and myself. And I'm very privileged to work at the Abramson Cancer Center, and I am available 24/7 if you have a question. So we start today, but we don't end the conversation today. Well, Dave knows very well that we had a lab in Montreal, and we actually made some very exciting observations. I think we made the first inhibition of brain tumor growth in the brain, blocking angiogenesis, which preceded a lot of the Avastin work, and it was Dave's PhD thesis. And I had labs in Baltimore and Bethesda and in Chicago and in Tampa. And that was always part of my, who I am. Because we know, as a surgeon, we can take out a tumor safely, but we know ultimately this is a biological disease. And one of our surgeons at Penn, Jeff Drebin, was on the cover of Time magazine with the word cure question. And so we started dream teams, and this goes along, Matt, with the theme of connectivity. And when I came to Penn, my chairman said, rather than starting lab number 441 out of 4,000 labs at Penn, why don't you go around the campus and harness the best minds and put them together and form a translational center of excellence? And that's what we have now. So we have this dream team, and we have lots of people here very dedicated to brain tumor work. Don O'Rourke is developing a vaccine we're very excited about. Christoph Davasikos and Rajini Verma are working not on genomics as much as on connectomics, although they're also tying in genetics with imaging, and that's a very powerful technology. And I could go on, but we have Jay Dorsey, Bob Lustig, working in radiation oncology, developing biomarkers as well as proton therapy. So what I found at Penn, like at Harvard, Yale, the usual suspects, we say, where there were many silos, and I tried, Matt, like you said, to bust down these silos, and we're making great success because people realize this is the way to do it now, that no one person is going to have all the answers. Although we have a great perspective, we bring a lot to the table, but it's been working together. So that's been very exciting coming to Penn. And some of the main areas that we're working on would be stem cells, immunotherapy, particularly immunotherapy, because Carl June and his group are now developing a new technology which is really providing cures to people with leukemia. And they have had remarkable success with formerly intractable leukemias. And and Donna Rourke and Hideo Ahata from Pittsburgh, but Don is the lead PI, will be coming out with a protocol soon this year for glioblastoma. And if we can apply that CAR technology to glioblastoma, we could have something very exciting to report. We are very involved in personalized medicine, as are many of the leading centers now. And if you come to Penn, you not only get your tissue removed in pathology, but you get at least a panel of 42 key genes, and you get a report. So we have the Center for Personalized Diagnostics. We're proud to be a member of the Adult Brain Tumor Consortium. This is an institution that I've been involved with for over 20 years, and we work closely with Hopkins, Harvard, the other institutions, and mainly NCI, so we get the first access to some phase 1 trials, and Dr. Desai is the leader in that arena. Proton therapy, I think we have one of the largest, or the largest in the world, with the Roberts, one of the newer proton therapy facilities, and that would be a whole lecture on proton therapy, and also neuroimaging and biobanking. So those are the main foci, those are the main hot areas. I'll keep to my time, so I'm going to focus mainly on some surgical aspects of it. But just to give you an idea of the history and tradition at Penn, the first computer, even before Al Masella's website, started at Penn in 1946. And it's amazing, they had this thing called the ENIAC, the Electronic Numerical Integrator and Computer. 1946, it was built by the Defense Department. They had a whole facility, and these people going around plugging in all of these wires. And all the power there, I mean, my iPhone puts that to shame. So we know we're living in an era of big data, harnessing information. How can this technology be harnessed to the patient with a brain tumor? So we'll leave that question there for a minute, and then as far as the biology goes, this one slide, because I won't be talking about angiogenesis today, but Howard Fine, before he left the NIH, did a beautiful job of summarizing the complexity. You can see the complexity of science. But this is what I see as a surgeon. Here's the tumor. But Dave and I know very well that the disease is more than just a tumor. The disease is spreading throughout the brain, and that there's many molecular and biological pathways. So it's very confusing to patients who just are entering this world of neuro-oncology. Well, Dr. Brem, if you got the whole tumor out, why do I need radiation and chemotherapy, and why is it going to come back? And David is going to explain that. But the interesting thing here is that Howard Fine also looked at the major pathways that we have, and has come up with 56 targeted agents, 56. Now this is, David is nodding his head, but it's actually unbelievable, because when we were in the lab in Montreal, we were still trying to identify targets. And I remember the excitement when we were looking at FGF the first time, when we had found the angiogenic factor in brain tumors. And now we know that there are dozens of angiogenic factors and dozens of inhibitors and dozens of cells, and that stem cells can become endothelial cells, and it's very complex. What's amazing is that we also know, in the wake of the Avastin 0825 data that was presented at ASCO this year, that it's unlikely that a single molecule, except for certain subtypes, will eradicate this disease because of its ability. It may be a stupid cancer, but it's smart in the sense that it can be like a chameleon and morph into different different pathways. And because of the redundancy, the current thinking in the field is that we'll need a combination therapy. We'll need at least 2 agents. And Dave Reardon, who's at the Brigham, medical oncologist, written a lot about this, has looked at all of these 56 compounds, and if you combine two compounds, actually you would go 2 to the 30th power, you would have about 2 million potential clinical trials. Each clinical trial can cost up to 100 million, so even with the whole United States debt, if we put it all to glioblastoma of 17 trillion, and in other words, it's a staggering, we have like more information than we know how to intelligently use. So that's another reason we're going to use these computers. And there's now a field of research using computer modeling to predict which agents can be effective before we go through a very expensive clinical trial. So, and I just had a thought, you know, if we can shut down, if somebody can shut down the government, whether it's Democrats or Republicans, can we shut down glioblastoma? You know, what about that? So what's my role as a neurosurgeon? So often I see the patient first, and I try to wear the two hats of oncologist and surgeon, but as a surgeon, my day job is to establish the diagnosis, very important, obviously. And it's not just diagnosis of glioblastoma now, is it mesenchymal, proneural, GMT, IDH. It gets pretty, and I want to steal your thunder. So it's more than just glioblastoma. We want to reduce pressure because a lot of the symptoms are due to the raised pressure. We want to cure if it's a benign tumor, and we want to do maximal safe resection. This concept of maximal safe resection, an important concept. And of course, we not only want to take bad things out, but we want to put good things like a gliadel wafer, if appropriate, in. So those are the roles of a surgical oncologist. The brain is fairly complex in its majestic anatomy and its complexity, and it's not just the brain. There's now 998 different regions at least, and everyone's tumor is different. Everyone's tumor in terms of size, what Matt showed his tumor in the cerebellum in that area, and the anterior superior vermis, and so that's very different than if it was in another location. On the other hand, our goals are always the same, is to keep you whole, to keep the patients whole, so that you come out of this with the tumor out and leaving the brain intact. So that's sort of the magic and the trick. How we do that, actually the Congress of Neurological Surgeons, Society of Neurological Surgery calculated that it takes up to 10,000 hours to be a concert pianist and about over 11,000 hours to be a neurosurgeon. So, but it's one goal. We just keep, we stay on that track. Although having said that, I admire being a concert pianist. I think we're not singers, we're not concert pianists, but we have this one, when we're in their operating room, we have a single purpose, to target the tumor. Now here's the thing about what I tell the residents, this is from my resident slide, the tumor is not just a round ball as pictured often in brochures. In real life, it actually may have tails, fingers, microscopic, and so what our goal is to find the epicenter. And it's not just a point of a target, but it's actually a very three-dimensional, so we build more like a geodesic dome. And our ability to do three-dimensional modeling has increased tremendously with computers. We want to study the outliers. We want to be able to remove little fingers if we can, little satellite lesions. We want to know before we get into the operating room what's operable and what's inoperable. We're going to have a game plan. It's very clear. We don't want to do what's called peek and shriek, get in there, and we get this sometimes from individuals who don't do a lot of this type of work. I got in there and it was really bloody tumor, and I got in there and there was swelling, and I got in there, so I backed out. That's called a peek and a shriek. We don't like peek and a shriek. I'm sure, I'm sure you never heard of that, but we do. We use what's called transsulcal and interhemispheric approaches, and I'll show some illustrations of that. In other words, in the old days, we used to take out chunks of brain to find the tumor, take out chunks of brain because there was swelling. These days, if you look at your hand and you wanted to get to the palm, you will go through the creases or the grooves, and the brain has these creases and grooves. I'll show you that, and we can do that without damaging tissue. So one of my jokes is I tell the nurses in the operating room, you have to count blood loss, you have to count the needles and sponges and clips. I want you to count the brain cells, because we started with 14 billion and we don't want to lose a single cell. So that's the idea, you know. They don't really count that. But. So again, one of the, I guess one of the changes in de-siloing our community, and I had the honor of being the chairman of the NCCN Guideline Committee, and I sat with 20 oncologists, radiation oncologists, surgeons from 20 centers in the United States. Try to develop a consensus, and try to develop a consensus among neuro-oncologists is a little difficult, but they all agreed that maximal safe resection is a goal for surgeons. And so these are the principles of brain tumor surgery, again, on one slide. And we do this gross total resection wherever possible. We'll try to get all the tumor out. And Matt, since you showed your tumor, and I'm a neurosurgeon, that was a nice tumor for a surgeon to remove because it was relatively round, didn't have a lot of fingers, and it was in an accessible area. So they probably did a gross total removal, you know, and that's huge. That's huge. Again, this is the guidelines for glioblastoma, recent guidelines. Multidisciplinary input planning, very important to have, to go to a center where lots of people are talking before they do the surgery, get a full plan, 9 yards. It's like, it's not just taking the tumor out, but what are you going to do afterwards? And get maximal safe resection. So, and again, this is from one of Spetzler's early works. And Spetzler, David is smiling, is a premier surgeon in Arizona, Barrow. And this is the way we used to do it is, we still do, is to have an approach, a corridor, and a target. And in this way, we can remove almost any tumor, even ones in the brainstem. But here, you see, this tumor is on the surface of the brainstem, so it's more accessible when they're on their surface. But what you can't do in this approach is you can't be cutting up the white matter in the brainstem, because that will lead to things like coma, death, paralysis, things, you know, very bad things. So we always used to think about two-point methods, think about the target and think about the approach. But I would say today we have a revolutionary different concept because for the first time we are able to see the brain wiring. So one of our wishes in my hypothetical Brian have come true. And I'll show you that. Because we have these corridors that I just mentioned, the little grooves, and this is the anatomy of the brain, but this is from Catani's Atlas, but Yassergil is probably the one who popularized this approach, that we can take advantage and exploit the little crevices using minimally invasive techniques so that we can pluck out the tumor without destroying the brain. This is from a nice slide from MD Anderson with Ray Sawai and Fred Lang's work, showing how they take this tumor out. It's pretty deep in the ventricle by respecting this fiber tract, which is the inferior longitudinal fasciculus, part of the arcuate fasciculus, going in there and removing the tumor without disturbing the tracts. And here they're using the Sylvian fissure going in and separating the frontal and temporal lobes, respecting the vessels, of course, and removing the tumor. So that's a modern neurosurgery. Take the tumor out, leave the brain intact, leave the patient whole. Simple. So that's it. And again, from the Ray's group, various approaches. So we look at the tumor now, we see how can we approach it in such a way that we do minimal injury to the brain. And now we're in a new era with white matter connectivity. In the past, these are the great neurologists from the 19th century. You've heard of Broca's and you've heard of Wernicke Center, and you've heard if there's a lesion there that you have a Broca's aphasia, and if there's a lesion here, you have a Wernicke's aphasia. And up to now, our ability to map the brain was only on the surface. Everybody, and myself included, was surface. We were like, we were focused on the nuclei of surface. And when Ted Kennedy had his brain mapping, they did on the surface. But today we can go subcortical, we can go deeper, we can look at the wiring. We were able to map what is in the white matter, which is very important. We have lots of technologies, and I'm going to get back to the white matter. But right now we are using, this is a list I gave of the various technologies that we use. And we use what's called stealth, the navigation, and we can merge it into the microscope so we can actually see what, as we're operating, where we are in 3 dimensions. We have dyes if we want to look at the extent of resection, look at margins. We can use ultrasound, intraoperative MRI. We can fuse it with functional. We can do cortitography. We can map out the electrical activity of the brain. We often at Penn use awake language mapping. When I was in France, I went and worked briefly with Hugh Defoe and watched his team. And they do it just the way we do it, or Penn we do it the way Defoe does it, or Defoe does it the way we do it in Penn, except we're speaking a different language, of course. But I found that you have to have a very good team to do this. You can't just have a random anesthesiologist, because I had one once years ago, and he just woke up the patient. He said, "Didn't you ask for awake anesthesia?" No, this has to be done very, very carefully and precisely. We use diffusion tractography, which we'll talk about, and wafers, of course. Radiosurgery, there's now a hybrid technology, which the surgeon does maximal safe. What's left, we'll do with Novalis, Gamma Knife, Proton, one of the conformal radiotherapy. And then new approach with laser is the autolit that Gene Barnett has pioneered. Now, in the year 2012, there are 2 very exciting scientific stories. One was the Higgs boson, which, if there are any rocket scientists here or physicists here, you probably know about that. Took teamwork. And the Human Connectome Project. So for the first time, we've been able to really map out all of the connectivity of the brain, and this has immediate surgical implications. This has allowed us to do a safer path through the brain, and I was able to, and the Philadelphia Inquirer did a story on our ability now to map all the connectivity. And honestly, sometimes the reality is greater than our dreams. We never dreamed that we would be able to have all of this knowledge, and it's based on computers. It's based on the things that like Al Masella map. It's based on the same type of computer software that allows you to do social networking. We're able to see how various areas of the brain talk to each other. Now, whenever we have a new technology, whether it's Avastin, whether it's this connectivity, whether it's stem cells, there is a foundation in Massachusetts called Gardner Foundation, and they came up with this curve. And this is whenever you have a trigger, you get tremendous peak of inflated expectations. Stocks soar, the vaccines are curing cancer, everything is, you're here at the peak. Then we find out that, well, maybe there was a patient selection, maybe the results can't be quite reproduced. People go at this trough of disillusion. I think this is where we are now with anti-angiogenesis. Avastin isn't the same Avastin that it was like 5 years ago. Everybody's on it. We were up here. But what is happening then, I think the good news is that in between those 2 extremes of the pendulum, we get into this slope of enlightenment and even a plateau of productivity when we start to really find out the true truth is, the real truth of this. So I think all of these technologies, connectomics, personalized medicine, vaccines, anti-angiogenesis, eventually we are making real progress, and we will find the right combinations of all of these technologies. So So just before I came to Penn, Surbi Jain from the Moffitt Cancer Center worked with me and on the tractography and looked at our data, and I was very pleased because I thought we were doing a pretty good job, but she showed that we had some really excellent results. And what she did is she didn't discover any of these tracks, but used all of them together by integrating the technology. And by taking ultrasound, integrating with fiber tracking, with fusing with functional MRI, we were able to get really results as good, if not better, than had been reported before. And she validated these with subcortical electrical stimulation. And as we expected, one of the factors is location, location, location. So that tumors that are located directly on what's described as eloquent brain will have, those are trickier tumors to remove and keep the patient whole. Whereas if we're in non-eloquent area, we can almost guarantee an excellent result. And if we do operate on eloquent, near the eloquent areas, the motor area, the speech areas, we may have transient deficits, but within 3 months or even sooner, the patients almost over 90% of the time recover, and patients will go for that because if we don't operate on them, they get steadily worse. So I think these combined technologies are having real impact. And with the technologies that we're using, where we were able to extend the resection to 2/3 had gross total resections. And I'm just going to speed up a little bit so I have time for questions at the end. So in conclusion, we're able to integrate all of these technologies, get a 3-dimensional image, and this will allow us to remove tumors, get maximal safe resection, which is our goal. I brought some of these techniques to Penn. Many of these techniques were developed at Penn, including tractography. Ron Wolf and others has been very active and does exquisite tractography. So here's a patient with a thalamic tumor. These are tough tumors to remove. We were able to get a complete removal, but we were able to map the motor area. This helps our approach. Here's another patient with a tumor deep in the temporal horn, and you can see the track right around there, and we're able to plan our surgery accordingly. Instead of coming from outside in, we go more medial out. We go inside out, so we can avoid. We know the functional highways in the brain. And this is really historic. It's not only being done at Penn, but it's done at several centers. But it's really a new era in imaging. In fact, you know, the word new era is used a lot, but in the year 2000, there were no papers on DTI, and now it's an exploding field. And it leads to the field of connectomics. There was this paper in PLOS Biology in which Hagman took 998 areas of the brain and developed these networks, and from that, a computer model of the brain, which looks like this. So these are different nodes and how the brain, how various areas of the brain talk to each other and how they're interconnected. And it's cluster hierarchical analysis, same thing that when you use Google and you put your wife's name, you get your daughter and your son, you get the brain is organized like that too, that there are edge and nodes and probabilistic, and they're connected. I think that was your theme, Matt, connectivity. Well, guess what? Brain has a lot of this. And actually, some of the same scientists who worked on the Human Genome Project are working on the Human Connectome Project. It's very similar of maps and pathways and false discoveries and nodes and all that stuff. So this tells us now that we have 3 different major bundles in the brain, and allows us as surgeons to start looking at the wiring diagram and work inside out. In the past, we always looked at the surface and MRI. This may even have implications. Tracy Batzer showed that we could use this technology to look at drug development and drug discovery as the brain heals itself. So we just received a grant to look at neural plasticity and recovery because we're interested how the brain heals itself. I know everyone in this room is interested in that. In fact, our mission statement is from discovery to recovery. And using this kind of technology gives us a powerful tool to get a quantitative handle on recovery. So this is a 23-year-old teacher who has some speech difficulty, left temporal heart area. Using the tractography, I'm able to see exactly where the corticospinal tract is, develop a three-dimensional model of the tracts in the brain, and able to target, this is intraoperatively, so I'm inside the tumor, but I might be a little bit cautious here because I know if I get too close, the patient may wake up with a motor deficit. We're still limited by the vessels, we have to respect that, so that's the intraoperative picture, and the patient has a good outcome. Now, I think someone did mention our President Obama, and he has now gotten into the Neuroscience Act himself. And he has declared this year that the United States government, bereft of dollars as it is putting at least $100 million, and in Europe they're putting $1 billion on this project. This is really exciting to map the human brain. He compared it to John F. Kennedy's famous moonshot, that we will put a man on the moon. So I think right now, it's very interesting to know all the connections in the fruit fly and so on. But right now, the immediate translation is brain tumors and how patients recover after surgery. So we are very, very fortunate, as patients, to be able to have this interest in brain mapping because it's going to translate to better outcomes, and as surgeons to have this kind of interest. So I'm working with the group at Penn in engineering and imaging to get all of this. And one of our residents, Luke Maxazin, will be presenting at the Congress. He's developed a quantitative scale to look at before and after surgery at mapping. I'm going to go right through all of these examples to save time and just get one other topic. This paper just came out, and Norman, is Norman here? We had dinner last night and talked about neurocognitive function and if there's a way to preserve neurocognitive function. And so we have published with Matt Ewan, who's worked on brain metastases and carmustine wafers, beginning at Hopkins. And Christina Myers, who is known, has devoted her life to looking at neurocognitive function. We looked at patients with brain cancer, and what we found, and I think this is a first, is that patients not only preserve function, but actually 40% of the time had an improvement that was sustainable in 3 domains: memory, executive function, and fine motor skills. This just came out in Cancer. So I want to talk about quickly immunotherapy, because this is a major topic right now at Penn. Dave Porter, Carl June have looked at what's called chimeric antigen receptor. You can now take T cells, modify them, train them, make them into smart homing devices to go to an antigen like EGFR V3. And so that's one of our targets. This is a platform technology. It's been very powerful, astonishing so that Novartis has been putting in millions of dollars, now partnering with Penn to do mass scale and to bring this to other tumor types, including brain tumors. So this is from a recent paper showing a big reduction in what was formerly an intractable disease. And finally, want to just mention that we have a whole range of, it's like a amazing place with all the technology. The proton therapy, this is Bob Lustig, very useful for pediatric tumors, and there's this whole range of technology. So which is the best technology? Well, this is one of our neurosurgeons, and Michelle Smith, and she's wearing one of these Google glasses. Maybe we'll have one day all of your information in your eyeglasses, and I'll be able to go and we'll have sensors and be able to tell which gene is activating the tumor, tell us, download which is the right drug to be giving that day. But I wanted to thank you very much. Last slide. What our whole goal is, whether we're in the laboratory, the operating room, with the technology, is to make what's invisible. See, the brain used to be a black box, and make it illuminated. And so the city of brotherly love, Philadelphia, happy to be here. Thank you. Time for questions? Yeah, so the question is, what do you do after surgery? And again, we do this, and I think the other talks are going to talk about that today, but we meet as a group, and generally I look at it as like a diamond, baseball diamond, that surgery is first base, because for the reasons I mentioned. The second will be radiation and or chemotherapy. Almost every patient with malignant tumor is going to have some form of radiation at some point. And chemotherapy is very important. Tumor is usually given at the same time as radiation. It actually works as a radiosensitizer. So Tumor, this is standard therapy for glioblastoma now. It's called the Stoop protocol. 6 months of Tumor, and then after that, it's a discussion with your oncologist. The fourth base, the home run, is biological therapy, clinical trial, vaccine, some other form of therapy. I didn't mention electrical field therapy, which has been approved for recurrent glioblastoma, but it's, as I said in my first slides, it's clear that surgery is very important, the quality of surgery, the maximal safe resection, but it's part of the answer, but it's not the full answer. So we don't undertake surgery unless we have kind of a consensus from a group as to the whole package. But it'll vary, of course, individual tumor and so on. Is the treatment the same for AA or GBM? It can be very similar. When we wrote the guidelines, NCCN guidelines, we debated that we include, but for practical purposes, it's the same guideline. It is the same page.
Excuse me.
You had indicated during surgery sometimes you may implant, what are they called?
Wafers?
Yeah, the wafers.
Right.
Under what circumstances do you do that? And is it usually on the first surgery, or is it if there's recurrent?
So the chemo wafers, called Gliadel wafers, were developed by Henry Brem at Hopkins, and they are FDA approved for both upfront and recurrent glioblastoma. So they can be used. It's one option.
So are there times when you wouldn't use those?
Yeah. So I tend not to use them if the tumor is diffuse or if because it's a local therapy. There are different forms of tumor. Pat Kelly wrote a classic paper. The ones that are well circumscribed I think those are ideal. For metastases, we've just published, I think they may have a place because they are, so the tumors that go across the corpus callosum, we probably don't want to use the wafers. Another reason practically we don't use a lot of the wafers, and maybe we should, is that some of the clinical trials exclude wafers, and we're very committed at Penn and other institutions to advancing the field through clinical trials. I didn't mention, but I meant to, Al, you have been such a champion for clinical trials. There's now 2 papers that show that if patients are on a clinical trial, even if the agent proves later ultimately to be ineffective, patients on clinical trials live significantly longer, equivalent to the benefit of radiation therapy, chemotherapy, or surgery, significantly longer. Why is that? Because once you're on a clinical trial, the intensity of medical therapy, every adverse event needs to be reported. You get 2 teams of nurses, the research nurse and the clinical nurse. So when I was writing the guidelines and working with the American Brain Tumor Association as a patient representative and patient advocacy, we put in the guidelines in every page, whenever possible, consider a clinical trial. Whenever possible, consider a clinical trial. You will get a benefit. It may not be the benefit you expect, but it will translate into survival and quality of life improvement.
May I just clarify one last thing? When you said you don't use those wafers when it transgresses the corpus, is that the midline?
The midline, yeah.
And why is that? Is there a brief answer?
Well, David could go into this more, but there's different. We tried to fit the therapy to the tumor type, and if the tumor is very invasive and diffuse, we're only treating part of the tumor. Now, you could argue that the tumor will recur locally, where the surgeon still should use it, but it won't get to all of the cells that are on the other side of the brain, just due to the limitation of diffusion. But it also, another contraindication is in the posterior fossa, where it's not been evaluated. Another contraindication is if the tumor is in the ventricle. Okay.
Now, do you, when someone's just been diagnosed with a brain tumor and you're going to go in for surgery, now do you consider the DC vax?
Yes, I'm very enthusiastic about DC vax. I was the principal investigator at Moffitt and will be at Penn, and I know Linda Lau, and the science behind it is very strong. So I didn't really have time to talk about immunotherapy in depth, but DC vax, the CellDex, we have open now at Penn, ACT 4 and REACT. We did ICT 107. Arthi Desai is the national principal investigator on new immunotherapy. Donna Rourke is developing this CART technology. All of us are like super excited about vaccines.
Now, do you know whether or not they would use DC vax, say, if they had to go back into the tumor?
I think the DC vax is up front, newly diagnosed, and depends how the protocol is written, but it's for newly diagnosed, not second stage or recurrent. Once it becomes commercially available, if it's shown to work in the phase 3, it's now in phase 3, then I think we'll be able to use it more liberally. Okay. What?
At what stage in the therapy would you introduce it? Would it be at the...
A newly diagnosed. Oh, I see. Yes. Yes. It takes a while to make the vaccine, so it's usually the radiation is given, and then, yeah.
Just an important point about DC vax, you need to have fresh tissue sent at the time of surgery. That tissue has to be sent the day of the surgery or kept overnight in appropriate media so that cultures can be done. If you have fixed tissue in formalin, DC vax is not possible. So that's an important thing to know.
My slide for the role of the neurosurgeon would be to provide tissue for a personalized vaccine, and DC vax is one of the most personalized vaccines you could have because it's about your antigens.
I'm at a different stage in my not in treatment anymore. A lot of people here are just initiating their treatments. I am almost 13 years past my treatment, thank God. But I have a question about the long-term effect of all this stuff that goes on. Have you done any research in I guess, facilitating any improvement on the long-term effects of all of this stuff, of all of the treatments?
So the question is, what is the long-term toxicity, and are we improving? And this is a huge area of research right now and a huge area of emphasis because, thank goodness, patients are living much longer and the quality of life becomes an issue. And so we're looking to minimize radiation injury, for example, and there's now evidence blocking the hippocampus will help preserve memory. The kind of study that we have just published in cancer showing cognitive improvement by withholding whole brain radiation only when it's necessary, not giving whole brain for patients with metastatic cancer to the brain. Trying to develop radiosensitizers so lower doses can have the same effect. and radioprotectants that can minimize the injury to the surrounding brain. And the same way we're looking at chemotherapy, because we all know about the fog and chemo brain, and we can now see the degree of injury using this tractography and using these techniques. And the things we use to cure the brain tumors can affect the wiring diagram: surgery, radiation, chemotherapy. We don't want the cure to be worse than the disease. So it's a very, very important area of research, and there's a lot of new attention being focused on it, new tools and new opportunities.
Dr. Brem?
Yeah.
You had mentioned earlier that with radiation, that Temodar is used. If I'm saying what you said correctly.
Yes, I say it's given at the same time as the 59 gray, the 6 weeks, because it was shown to work by Roger Stoop in the European EORTC NCIC study, but also in the laboratory it's shown that it can potentiate the effect. It improves, it makes radiation, it like turbocharges radiation, so it makes it more powerful.
Do they still require that, I'm going to say in my case, they were looking for the genetic code of P19 to see if Temodar would work properly? Is that still done?
Well, molecular markers are very, very important, and we talked about it last night at the speaker's dinner with Dr. Zagzag, and I think he's going to give a whole talk on matching treatments with the P19, 1P19Q code deletions and so on, so in the MGMT and the various markers. So yes, the molecular composition of your tumor extremely important in terms of outcomes, treatment, response to therapy. And we're seeing now actually some of the Temodar with radiation is so effective that, as you know, about pseudoprogression, which I think is another topic that you'll be tackling, and it's a very important clinical issue. So sometimes it looks like the tumor is back or progressing when in fact it's not, because we've just been so effective at destroying the tumor, and we get, if we operate on it with just dead tissue, but it can look by imaging techniques like it's a live tumor because it breaks down the blood-brain barrier. Yes? I think there's another question.
Yes. With resection of tumors, there's not only damage to the immediate area, but there could be damage to other structures right around it, like the hippocampus.
Yes.
The connectivity mapping, does that help define functional effects of damage to certain structures, or is that a separate issue? Because there seems to be a lot of concern when you take out, for example, the hippocampus. What is it actually going to affect?
Well, that's a great question. Do the connectivity maps help in terms of sparing the hippocampus? And so our connectivity maps, we don't really zero in on the hippocampus. We're looking at visual pathways, speech, language, and motor. There are infinite pathways we could be looking at. The limbic system would be difficult. The emotional centers and memory would be difficult, but theoretically possible. What we do for the hippocampus is we are doing awake cases in that mesial temporal lobe, and Hugh Defoe has shown that if you remove the hippocampus neuroglioma, you have no deficit in terms of his results, in terms of memory, and in fact you have better seizure control. So this is for low-grade gliomas near the hippocampus. And he strongly advocates not only doing lesionectomies, which I have done for years, in other words, to take out the tumor, leave the hippocampus, but to go a little bit beyond. So we're tending to do a little bit more. The brain has plasticity and can recover on the other side. Stan, am I going over time because there are a lot of questions?
I think maybe two more questions quickly.
Yash had a question, yes.
You talked about, you said something about pseudo-regression.
Pseudo-progression.
Progression. Regression is the opposite of progression.
Yes.
can the therapy on, can it, when the MRI scans are done every month or every 2 months, and the therapy I'm on, for example, Avastin, can it mask the tumor, so the medication can mask the tumor so it doesn't show, even if there is a growth in the tumor is active, MRI may not show the growth because of the medication, because of Avastin? Is that possible?
Yeah, the question is, with therapies and pseudoprogression, especially Avastin, can it look like the tumor has disappeared, but in fact the tumor is growing? So we know with Avastin, it blocks the breakdown of blood-brain barrier. It blocks the vascular permeability factor, which is VEGF. And so we get what's called steroid effect. It looks really like a tremendous response. But believe Dave Zagzag and many neuropathologists have shown that also the tumor shrinks because it blocks the blood supply, and the tumor does depend on blood supply. So when we see the shrinkage after Avastin, we do believe the tumor is actually disappearing, as well as an artifact from the drug. On the other hand, and this is a whole talk, but just to make it quite simple, Avastin has another biological effect, and it can stimulate the pro-invasive, which we have really only focused on in the past, angiogenesis, tumor volume, but we know that it can change. And we used to look at T2 FLAIR images, and we used to say that's edema, but now we know the tumor infiltrates into the brain post-Avastin. And that's why the new criteria for looking at new drugs and new clinical trials is called the RANO. It's the revised assessment in neuro-oncology, RANO. And it looks at T2 FLAIRs as well as T1 with gadolinium. I may be a little technical here, but we have now ways of detecting that change in the growth pattern of the tumor. So, yeah.
Could you recommend the maintenance therapy for the GBM long survivor?
So, what kind of therapy for a long-term survivor for GBM? Could I recommend what therapy?
Maintenance.
Oh, maintenance. Yeah, that's a tough, you're asking the tough questions here that I think would challenge our top medical neuro-oncologists. So what should we be doing for patients who are long-term survivors, knock on wood? And should they remain on chemotherapy, which is cytotoxic, genotoxic, toxic? Should we take them off? So some oncologists will give a drug holiday. That's what our medical oncologists do for long-term survivors for melanomas or lung cancer. So I think it varies with patient by patient, oncologist by oncologist. There are no NCCN guidelines for maintenance therapy yet. When I was on the committee, that's a tough one. Some people say, look, even for Avastin failures, you better not stop Avastin, because if you take the drug off, you may get a rebound of FLAIR. And I wouldn't mention any names, but some very strong and prominent people believe that even, so that's kind of a counterintuitive. If the tumor has escaped, why would you still suppress that tumor? Because there still may be other cells that are responding to that tumor, and it could get worse. So it's a tough question. I don't really have a great answer how long you should continue successful therapy. And I think a lot of physicians would give a drug holiday. It's a great problem to have. We never had that historically in neuro-oncology. Sure. Yeah.
Okay. There is many claims of that chloroquine and that malaria medicine sort of opened the blood-brain barrier. So it would be a good complement for temozolomide, Timodar. Is there data, sufficient data on that? Will it be worth to take it along temozolomide?
Is there sufficient data on temozolomide for?
In chloroquine. Chloroquine, taking chloroquine.
Procaine?
Chloroquine, the
chloroquine.
malaria
Oh yeah, okay.
disease.
So okay, yeah. So at our institution at Penn, hydroxychloroquine was developed by Myrna Rosenfeld and put to phase 2 trial. Looked very good. I think in further trials it has not panned out as an agent, although there's a lot of good laboratory data and initial clinical data. So maybe chloroquine might work like other agents that work in the laboratory, maybe as part of an ultimate cocktail or part of a combination therapy. Yeah. Go ahead.
I'm a long-term survivor, 25 years.
Congratulations.
Sorry. 25 years they said you could have radiation once. I've had radiation twice, and I laughed it off. There's tricks and things you can do to compensate for the problems you might have for radiation. But my question to you, what do you suggest where the protocol Avastin, which you say they give T2 intensity flares.
Mm-hmm.
It's like a...
Yeah. Well, it's a big topic and it's very close to my heart, and as you know, we worked for about 30 years with, beginning with Dr. Folkman and Dr. Zagzag on this topic. I was privileged to write 2 editorials in Journal of Clinical Oncology. I've heard about that from Matt, about JCO now being in young kids. And the first one was Taming Glioblastoma by Targeting the Vasculature. I wrote it with Eric Wong. Actually, he wrote most of the editorial, but I wrote the title. He liked the title. And the fact, we thought it was a eureka moment. It was really a eureka moment that we thought, wow, after all those years, finally, we got it. I was so happy. I was on the top of that Gardner curve. And then, and Henry Friedman called me up and he said, you know, and this being taped, so he said that he had been somewhat skeptical, but he saw firsthand and he was so excited about anti-angiogenesis. And so we thought we were in a new era, and we wrote this editorial. And we had many cases, and the brain tumor community was so excited. I was head of NCCN when we endorsed it before FDA approved it. So I'm very enthusiastic. The data that came out of UCLA, the data that came out of Duke. So what happened? So I know, Matt, is your organization the Cancer Stupid? Stupid Cancer? Yeah. It's not that stupid. The cancer is actually very devious, very wily, so it developed a way to escape the Avastin. And what it is the VEGF the receptor, the molecule, it is pro-angiogenic but also anti-invasive. So when you're giving Avastin, you may be driving invasion. You may. And, or there are cells that just find a way to look at pre-established vessels. This is called co-option. And by the way, David, I think you were the first to observe this phenomenon and then later write up, but it goes back in our original AJP paper that you observed anti-angiogenesis, and we were very excited about blocking it, but there's a slide there that shows malignant cells running along established vessels. So the cancer, stupid as it is, it found this way to outsmart the therapy. That's a problem. So this will lead to David's talk about how to develop anti-invasion as well as anti-angiogenesis. That may be the ultimate combination. I firmly believe we can find the cure. And 25, 30 years ago, when I heard about AIDS, and I remember Magic Johnson making his announcement that shocked the world, that Magic Johnson, the super sports hero, had AIDS. Tom Brokaw, when he announced it, he said, "The news is so overwhelming that I can't even deal with the news as I announce it. It's stunning." We thought he was a dead man walking. Magic Johnson is in the news now. He's the owner of the LA Dodgers. He's one of the wealthiest Americans. My prayer is that everyone in this room, that we'll get our act together and come up with the combination therapy like the folks with AIDS. They did it by activism, they did it by patient groups like this group, through scientists like Dave Zagzag. And I'm sure that the ultimate cure is out there. And I hope to be an instrument ultimately, but a lot of us, like Al Masala, have done so much to bring people together, to break down the silos, to get the right combinations, because cancer is not that stupid. Yeah.
Thank you, Dr.
Thank
Brem.
you.